Let's talk about ultrasound-guided needle placement. All right, so we all know that with ultrasound, if you read the literature, ultrasound decreases the complications from central lines. And it really doesn't matter which site you're looking at, you will find a decrease in the complication rate when you use dynamic ultrasound or watching the needle go into the vessel. And this only makes sense. Here's a subclavian vein, and we can see the needle. We can see how close we are to the pleura where we would give the person a pneumothorax if our needle went too far. And here it goes through the back wall, but yet we saw that we did not cause a pneumothorax because we could control the needle tip because we were watching it. However, even though our goal is zero complications from central lines using ultrasound, that if we don't know how to use the ultrasound properly, we can actually have an increase in our complications from central line because we think we know what we're looking at and we're looking at something completely different, and then we cause the patient harm. So patients are always the first priority, and so we want to make sure that we are doing the appropriate, most up-to-date technique with our ultrasound as well as needle placement. So we use what's called an ultrasound bundle. It's the 5-pointed star again, machine hygiene, setting up the machine the best proper way, right transducer, sterile sheath placement, and then visualizing the needle tip all the way through the procedure. So for us, machine hygiene, what we're going to use is called Oxivir TB. It's the white top hydrogen peroxide based wipe. It kills the bacteria within 1 minute by drying. Excellent. That is our primary choice. Our secondary choice is the gray top Sandy wipe AF3. This is an alkaloid based. It takes longer to dry. It's equally as effective, but we prefer the hydrogen peroxide Oxivir TB. When we set up our machine, we always want to set it up in the line of sight. We want to be able to look down at our hand and up at the machine, down and up in the same plane. We don't want to put our machine off to the side. When we do this, our head is turning as we're looking at the machine and taking our needle out of plane of the transducer in the vessel. So down and up is what we're looking for. For transducer selection, you are always going to use a linear transducer. One thing to remember, though, is that some machines have very specialized linear transducers and do not image needles very well because they're a diagnostic tool instead of a procedural tool. If you're using some machines like Sonocytes and GEs, point-of-care machines, generally there's only one linear transducer and there's not much to worry about when it comes to visualizing the needle. For other machines, you may need to use a specialized transducer that is meant for imaging needles. For the Philips here in the picture on the left, we use the hockey stick transducer that is meant for imaging needles. So make sure you know how to use your machine before you start. Now, placing a sterile drape on your transducer can take some practice. There is a technique to this. But we don't ever want to just use sterile gloves to cover our transducer. As you can see in the picture on the right, there is a cord in the sterile field, so that is not maximum sterile barriers. So we're always shooting for having a specialized transducer cover that goes from the tip of the transducer all the way off the sterile field. Now, placing this in a sterile field can be a little bit of a challenge. What you want to do is establish your sterile field, place your sterile transducer cover in the sterile field, use gel inside the cover. That gel has to be against the transducer. Then you can use your observer to hand you the transducer so that you are not contaminating the sheath. Have your assistant pull the transducer cover tight, and so whenever your transducer is in your sterile field, it is also sterile. One important thing to remember here is that if whatever goes off the side of the table, even though it's got a sterile sheath on it, once it's off the side of the table, it is considered not sterile any longer. And so you want to clip it if you have to, but once it slides off, it is no longer sterile. Now, let's visualize our needle tip. So there's a lot of ways you can talk about ultrasound imaging for vessels and ultrasound imaging of needles, but we want to do the best practices so we have the best outcomes, and that is by dynamically imaging the needle all the way down to the vessel. Now, there's two ways of imaging the vessel. Remember, these are pipes, and generally you're going to have two pipes running in parallel. A central vein always has an artery next to it. So if you're talking about the IJ, you have the IJ vein and the carotid artery running parallel. So you have two pipes running the skin. When we take our probe and come across it, the pipe looks like a circle. When we're parallel, it looks like two parallel lines, the anterior and posterior walls of the vein. Now, no matter how we're going to end up looking at the vessel, we always start in cross-section where it looks like a circle. And the reason is because we can push down with our transducers. Vein are low pressure, so they wink at you very easily with transducer pressure, whereas arteries have higher pressure and will pulsate open with systole. Nerves, clotted vessels will not compress generally, no matter how hard you push. So here's a picture of an arm. We have several pipes running up and down the arm. We can see in cross-section that the vein is winking at us with a little transducer pressure, whereas the artery is just indenting, and the nerves above it are staying the same. So now we can identify the artery, the nerve, and the vein, and we can pick our appropriate target. This is the common femoral vein, and as we press down, you can see that the arteries are compressing, and in fact, we're almost causing a tourniquet-like effect by stopping blood flow, yet the vein is not collapsing. That's because there's a DVT in this vein. So what you need to remember is if you're doing venous vascular access, the key is veins should collapse very easily. If they don't collapse easily, number one, there's something wrong with the vein, or number two, you're not looking at a vein. So if it does not collapse easily, it's not a vein, and you should not be using it for venous vascular access. Now, the compression technique. One caveat here. You cannot do compression in long axis. You don't know in long axis where it looks like two parallel lines if you're compressing the vein and it's disappearing or you're sliding off to the side. So we only do compression in cross-section or short axis. So we're going to talk about three methods of visualizing the needle. Short axis or cross-section is the easiest to learn and conceptually the easiest to master. However, we are going to also show you long axis or longitudinal so that we can show you the best practice, which is a mixed approach. So in short axis, remember the vessel looks like a circle. The needle is going to look like a dot. It's a cross-section of the needle, and we're putting the tip of the needle into the middle of the vessel. So it's like putting the bullseye in the target. Now to do this, what we want to do is we want to place the needle under the long face of the probe when the probe is directly over the vein. The thing is that the needle tip and the needle shaft look the same, so we want to advance our probe ahead of the needle and watch the needle pop into view. Pop into view. So probe, then needle into view, probe, then needle into view. That way we know we're looking at the front of the needle tip. And here we have the needle tip sitting in the vein, and we can slide up and back and make sure that we're looking at the needle tip sitting in the middle of the vein. Now, that's how you do it. Just remember that if you don't see the needle tip popping into view, you don't know if you're looking at the needle shaft or the needle tip. We want to make sure we're seeing the needle tip because it's what pops into view. When we see the needle tip, we stop moving the needle into the vein or into the tissue. We stop and move the probe, then needle. If you don't move the probe, the picture's not going to change. So here we are, we're set up, we're directly over the vein. We advance our needle, the picture did not change. This gives people a false sense of confidence and the needle keeps on going deeper in the tissue, and you may hit the vein and you may get a flash of blood, but more than likely you will go out the back wall of the vein and then your wire won't feed. This does not necessarily cause a lot of complications. However, it could be another structure like an artery sitting back there and you think you're in the vein, but you're really in the artery, and then you proceed with the procedure and have a bad outcome. So here is one of those. So we have the internal jugular vein in the middle, and we have the carotid artery off to the side, and this is a hubbed central line needle. That IJ is 1 centimeter deep and it's 1 centimeter thick, and this 10 centimeter needle is all the way to the hub. So where the needle tip is off the screen. We don't know what that needle tip's doing. We see movement of the needle, but that is the needle shaft going through the vein. That is not the needle tip. So again, we want to walk that needle tip all the way down, imaging the needle tip the whole way to make sure that we're doing a true dynamic procedure. Now in long axis, we turn to where the vein has two parallel walls. The anterior and posterior wall are just bright lines. And then we insert our needle under the short face of the probe so that it's a bright line, and we place all three of those lines together. Seems very easy, and in practice is quite difficult. Here we have our vein, and as if you notice, when the vein is getting a little out of plane, the vein wall starts getting dull as it is here. The needle will also get dull when it goes out of plane. And so the challenge here is to know which side of the vein the needle's on and then to line them all up. So conceptually, this is a little bit more difficult than that cross-section or short axis approach. It is nice, though, because you can see the whole extent of the needle. You can see where it went and where it's going, and you can see it from front to back. Here's an example in a real patient. Again, we're compressing in short axis so that we know the vein. We keep the vein on the screen the whole time. So that's still the vein. When we get to long axis, we have the walls very bright. We insert our needle under the short face of the probe. We can see the carotid artery posterior in this real image. And as the needle comes down, we can stop before we go out the back wall, before we even get close to the carotid artery. This is a safe procedure. But in reality, this is more difficult than it seems because you have to rotate from short axis to long axis without letting the structure go off the screen, because once you get to long axis, two parallel lines, you can't do the compression technique anymore. You don't know if you're compressing because it's a vein or you're sliding off the side of an artery. So the pitfall with doing long axis is that you cannulate the artery. The pitfall from doing the cross section or transverse is that you don't follow the needle tip down and your needle goes a lot further, maybe into the artery posterior. So the best technique is going to be a combination technique where you use the best of both of these techniques. So with this mixed or combination approach, we're going to start in short axis with the needle at the top of the screen, our vein lined up, and we're going to move the probe. When we move the probe, the needle's going to disappear. Now we're going to move the needle. When we move the needle is going to pop into view. When we see that needle tip, we know it's the needle tip because it's the front of the needle. We stop moving our needle. Now move the transducer. The needle is going to disappear because we've gone beyond the needle tip, and then advance the needle until the tip is seen. When the tip is pointing towards the vein, when the needle is pointing towards the vein, when it's anywhere close, we can take our transducer off and we can go find the needle in long axis. The needle is pointing to the vein, and then we can finish our procedure off by sliding the needle through the vessel wall and assuring we have great placement of our needle. Now, this is what it looks like in a phantom. We start off in short axis. We see our needle at the top of the screen. We advance our transducer until the needle disappears, then needle. We can redirect while we watch the needle right to left, but we don't want to see the needle move without it popping into view. So once we're close, we can turn our probe long axis, find the needle, don't care about the vein, find the needle points at the vein, and then we can finish it off. Now, this technique is great for placing central lines, but what it is even better for is when you're in a short axis approach and you lose your needle tip and you're not sure exactly where you are. Instead of removing your needle and starting over, if your needle is pointing right at your vein and you know it is, then go find your needle, because generally that's easy to find, and then finish the procedure off in long axis. So this is a rescue technique. Here's what it looks like in a cadaver. We start off in short axis. This is the internal jugular vein. As we're coming down, we can see the needle tip. It's very difficult in this cadaver video, but we see the needle tip. But even though we're close, we don't know exactly where our needle tip is. We know it's pointing to the vein. So we can turn and find our needle in long axis. We're scanning for it. We're scanning for the needle. Once we find the needle in long axis, then we can advance our needle and not go out the back wall. This is a perfect rescue technique.